Well, again, thanks for having me. Appreciate it. It's a real pleasure to have been part of Danielle's team for such a very long period of time. Um, this is really an honor for me. As Danielle mentioned, I do sort of cross a couple of different boundaries. My background is in engineering, but I am a patient. I've been a patient for almost my entire life, and so we'll talk a little bit about that. So the talk I'm giving is really an intersection of healthcare policy and technology, and it's my perspective. It's going to be somewhat subjective in a lot of ways. I've broken this down really into three parts. We'll talk a little bit about who I am, and then I'm going to share with you a story, a presentation I gave at the Health 2.0 conference about four years ago, back in 2015. And then we'll get into talking about how we balance policy and technology together. Sometimes policy tends to hold back technology, and then vice versa. Technology tends to move a lot faster than policy. I think we all kind of can pretty much attest to that. And then my favorite part is looking ahead. I tend to be sort of a technologist. I love technology, but it isn't a panacea. And so we'll talk a little bit about what I see going forward. As Joy had pointed out, one of the aspects of our future really is cultural, and so I want to touch on that as well. So just a little bit about me. So I've been in technology for a long time. I got old somewhere along the way. I used to be a kid. My hair fell out, and I've been 30 years in technology. But at heart, I'm a systems software engineer. I own a couple of companies that are really focused in consulting in the technology space. Originally from Chicago. Anybody from Midwest? Yay, excellent. I moved here in 1989 from the University of Illinois down mid-state. I came to work here originally at Microsoft, and I spent 10 years there working on Word and Flight Simulator, so my background is not necessarily in healthcare. I then spent another 10 years roughly working in satellite engineering and aerospace in DoD, military, and government, and that's a very different world, and again, not healthcare. But what was interesting, probably almost 10 years ago, we sort of shifted when the ACA kicked in. We started getting customers that were interested, that were in the healthcare space, that were interested in healthcare issues as they relate to technology. And it was interesting because at about that time, one of my colleagues came to me and said, we were doing bomb yields for city centers, and he said, this is bad karma. What can we do instead? And I said, well, it just turns out that we're getting customers interested in doing healthcare work with us. Would you be interested in that? And he said, yes, please. So we sort of fell into healthcare backwards. So my experience in healthcare is less professional and in a lot of ways more personal. And we'll talk a bit about me as a patient in just a moment. I also am very involved in the community, as Danielle had pointed out. So my interest is really based here in an organization called Northwest Kidney Centers. I'm vice chair for the Board of Trustees and past chair of their foundation board. I'm also involved in the Linux Foundation on a project called Hyperledger, which is, we'll talk a little bit about this at the very, very end, but it's blockchain technologies. And you've probably heard of blockchain, and I'll get to that in just a moment. I also chair within that organization a really fun group. It's an international group of healthcare professionals, over 1,000 folks that all have interest in understanding how to use blockchain technologies as a way to solve very complex healthcare issues. That's great fun. It's like I feel like I'm a kid in a big, very big sandbox. And occasionally, I do serve as an advocate. I don't, Danielle knows this, I don't consider myself a patient advocate. I'm not a very good advocate. I'm opportunistic. I love to speak with people and share my stories. But I don't know what an advocate is. I'm not one. We have Debbie, who's on our team. She's a great advocate. I did have an opportunity to speak in front of Congress some years ago as it relates to Medicare and dialysis. And then, of course, technology is sort of the other thing that I do. And so whenever I have an opportunity to try to get groups of folks together and talk technology, it's a great experience. So as I had mentioned before, there can be three parts. And so really, I'd like to sort of define from my perspective what patient engagement is all about. And I'm going to give you a talk here that I gave about 4 years ago called, it's part of the Magic Wand Project, and you'll sort of get the sense of what the interlude's all about. And then I wanted to sort of let you have the spoiler in advance because you might want to take a nap. It's early in the morning. But the upshot of it is really this is my view and this is my patient view on what engagement's about. It's a very personal thing. And really it's about the communication between patient and provider, and it really is a collaboration. And it's, I believe strongly that a patient has absolute access to their data, and we'll talk about that a little bit later. And then finally, it's all about patient satisfaction. I mean, I'm not doing it for my health, but actually I really am. And so that's kind of the takeaway here is that from a patient perspective, everything that I do, everything that we do in this room today really needs to roll back to what the patient experience is about, and making that more facile and easier from a patient perspective. So, you know, a lot of the back-end work that maybe never sees the light of day from a patient perspective is going to be seen by virtue of the fact that the patient is happier, they're more engaged, and at the end of the day, their outcomes are going to be much better. So on that point, I'm going to grab my presentation here, my speech, my talk. So this is called the Magic Wand Project, Learning to Live My Healthcare, My Life. And again, this was presented originally at the Health 2.0 conference down in San Jose back in 2015. So good afternoon. If I could wave a magic wand and change one thing about healthcare, I would change every one of us here today, and I would change you, the patient. I believe that healthcare succeeds through individual patient triumphs. Within the healthcare community, our role as patient is to accept the responsibility of learning who you are, to educate yourself about your illness or condition, and to work cooperatively as peers with your healthcare providers. Only then do I believe that today's healthcare can truly succeed. And when I speak of the now familiar term called patient engagement, I speak not so much of external solutions, strategies, affordances developed to enhance or underscore patient interaction, but rather my appeal is for you, the patient, to actively engage the healthcare world around you. After all, it's your healthcare, it's your life. I'm here this afternoon to talk to you about how I learned to live with a chronic illness and to share with you my own observations and perhaps insights into why I believe advances in today's healthcare must be intrinsic, more about you and me, the patient, and the importance of patient engagement, patient education, and patient responsibility, and perhaps less about the myriad technological advances that seek improvements across the healthcare industry. Now, that last statement might be particularly interesting as I am beyond being a full-time patient, professionally employed as a software engineer. So I make my claims not as hyperbole, but in the context that, to me, improvements in healthcare must be considered holistically and with a singularly strong patient-centered approach. And I say this in large measure because I, like so many other patients dealing with chronic illness, have had to learn to live a very patient-centric life. My name is Rich Bloch, a native of Chicago. I now live in Seattle with my wife, Diane, of 19 years. I came to Seattle by way of Microsoft right out of college back in 1989. Today, I own a systems and software engineering company, which has increasingly become involved in, of all things, healthcare engineering. I also volunteer about half my time to community healthcare initiatives and activities, currently serving as a member of the Board of Trustees and Foundation Board for the third largest nonprofit kidney care organization in the U.S. called Northwest Kidney Centers, which also happens to be the creator of modern-day dialysis services, invented right here in Seattle back in 1962. And I mentioned that interesting fact because I have chronic kidney disease. I was born with a genetic kidney condition called polycystic kidney disease, or PKD. PKD is pervasive. It's the fourth leading cause of kidney failure, singularly accounting for about 10% of all kidney failures worldwide. And importantly, PKD today is still an incurable disease. I first learned I had PKD back in 1980 during a high school football game when I got a quick elbow to the gut. It knocked the wind out of me, but I really didn't think much much more of the accident until later that day when I started to, not feel so well. I went into the bathroom to use the urinal and realized that I was bleeding internally. Something was wrong. I found a payphone. Yes, and these are in the days when there were no smartphones or not so smartphones. Called my parents, and off the emergency room we went. I was rushed right into surgery to have my ruptured left kidney removed. After the procedure, though, the surgeon explained that he had instead decided to remove only part of the damaged kidney and leave what remained because he had discovered while in surgery that I had this thing called PKD and knew then that I need every bit of my remaining kidney function, however impaired, for the future health of my young life. So at the age of 15, I learned literally overnight what it meant to have a chronic disease. And it was that moment that I began to learn what it meant to be an actively engaged and responsible patient. I became invested in my healthcare, all aspects of it. I spent so much time learning about kidney disease, my health became my hobby. I learned whatever I could about this unusual disease. I learned about how kidneys worked and what PK did to destroy their function. I learned to stay kidney healthy through careful diet and exercise, and I learned to stay heart healthy too, because, as it turns out, PKD patients like me didn't die of kidney disease. Oh no. They died instead of heart disease. Wow, this was getting hard. All of this research and learning before the existence of something called the internet. Our public library was my best resource for this peculiar hobby. And after exhausting the resources there, I began to ask my doctors for white papers on PKD, potential new drug therapies, and kidney disease research, and learned how to read them, which, to be completely honest, was never particularly interesting. But I persevered. After all, this was my life. What better motivation is there for staying healthy than to stay alive? I once complained to my mother, who also has PKD, about whether I really had to take such extreme care of myself. And she said, "Oh no, you always have a choice. You can take care of yourself and stay healthy, or you die." Well, that was real motivation, and that's true. That is, she still says that to this day. And so I did choose to take care of myself. After all, it was my responsibility, though the progress of my kidney disease sometimes managed to outpace me. 10 years later, it's 1990, graduated from college and moved to Seattle the year prior, and I'm a young, exuberant software developer working at Microsoft. I was at the top of my game. Life was good. One day, a colleague glanced over at me with some concern and said, "Gee, Rich, you don't look so great. You feeling okay?" I really hadn't been feeling well, but as young people tend to do in their cavalier ways, we think it's anything but something serious, and certainly never about health. And besides, it had been 10 years since my accident, and I felt I had everything pretty well under control. I was loving life. But new to Seattle, I really was due to find a local nephrologist and thought maybe this was as good a time as any. I had my first appointment and at age 25 was immediately diagnosed with acute hypertension, which I think everyone knows is high blood pressure. And if I recall, it was somewhere in the neighborhood of 170 over 120, so that's significant. With that pronouncement, I knew exactly what those numbers meant. My kidney disease, my hobby, had been quietly progressing along with or without me. In an effort to perhaps regain some level of control over this endless disease progression, I once asked my nephrologist for a piece of graph paper so that I might be able to plot and maybe even predict when I might expect certain disease-related events to take place. It made sense to me. Well, my nephrologist chuckled, but understood my request and returned with a piece of graph paper. Now, I'm going to get a little technical here and ask you to recall your middle school math for a moment. I had expected my nephrologist to return with something called quad-ruled graph paper, which are the little squares on the paper, and they're all sort of equal-sized, and I think most of us are familiar with graphing simple equations with it. He returned with something called log-ruled paper. I immediately realized the implications of this. While I had been expecting my disease progression to be linear, changing about the same amount over time, the log-ruled paper meant that things were changing in a very nonlinear way. In my case, changing increasingly faster over time. As disheartening as this realization may have been, I did learn more about what to expect, and so with one clean piece of log-ruled graph paper in hand, I dutifully plotted my eventual kidney failure. In hindsight, with not so great accuracy. That made me feel good. Skipping ahead to age 47, as much as I'd continued to be diligent and responsible in the management of my disease, at the end of June in 2012, my kidneys finally, and yes, even somewhat expectedly, did shut down. And I began a renal maintenance therapy called hemodialysis. Inasmuch as I felt that I had fought and lost a lifelong battle against kidney disease, I had sometime earlier rather willfully declared to my nephrologist of 17 years that I would absolutely be the one exception to kidney failure due to PKD and never need dialysis. Yet I was, in the end, accepting of the situation. Those years of diligence and learning and committed involvement as a patient with PKD, with chronic kidney disease, in chronic healthcare management, my healthcare management, all of it had helped me get this far in my life. Recalling my mother's words about always having a choice, I was alive. For the next year and a half, I learned to live and work productively with hemodialysis. My wife, Diane, is my caregiver. With my wife as caregiver, I dialyzed 5 times a week at home while I slept. It was difficult, but not insurmountable. I saw it as another challenge, another aspect, another facet of my hobby in managing my own health care. And as I had done for so many years, I learned all I could about how dialysis worked, why it worked, how the dialysis machine itself functioned. Remember, I'm an engineer after all. And what it meant when dialysis machine sometimes happened to not function. And with the advent of social media on the internet, I learned that there were many others out there in the world of chronic disease and illness who were enduring the same kinds of issues that I was. There were patients just like me out there who understood what it meant to live their entire lives with some kind of chronic, forever illness, and that learning to live was their hobby too. Whole websites and forums were being dedicated to kidney disease and dialysis, and we were becoming a community of patient activists, like-minded and looking to collectively improve our lives and the lives of so many others. I often think, even today, of how my own actions as a patient, my decisions and indecisions, advances and missteps, everything might affect those newer patients queued up right behind me, who are just today, this very moment, learning that they too have kidney disease or some other chronic illness, and how I might make their lives just a little bit better somehow. And were they too to do the same, how they might impact the lives of patients queued up behind them. That's my role as a patient. That's my responsibility as a patient. At the end of 2013, I received a fateful call early one morning. Kidney was waiting for me, University of Washington Medical Center here. Early that next morning, I was wheeled into the OR in preparation for a kidney transplant. And just as I felt myself slipping off into unconsciousness, I saw the surgical staff gather around a small side table just over my right shoulder. Between their gleaming white scrubs, I glimpsed the pink-purple blue of my new healthy kidney. Those nearly 35 years of effort, study, and commitment as an involved patient, responsible to myself, responsible for my own health care and my own life, had delivered me to this singular, beautiful, life-changing point. Today, I stand here before you, healthy and thankful for the life I've lived thus far. It's a rare gift to have this gift, knowing how fragile and difficult it's been to curate over these many years. As a patient, we've all heard from friends and sometimes even those closest to us exclaim how awful it must be to be saddled with a life full of chaos, uncertainty, and pain. But I don't see it that way at all. If I had to do it again, I certainly wouldn't change a thing. My life has been an honest and daily commitment, and with any true commitment, you recognize the purest of values, of what it really means to live, day to day and moment to moment. I've told you my patient story here today to reinforce the simple fact that I believe that healthcare succeeds through individual patient triumphs. Within the healthcare community, our role as patients is to assume the responsibility of learning who you are, or committing to learning about your illness or condition, and working closely and cooperatively with your healthcare providers so that we might all succeed. Remember, you always have a choice. It's your healthcare, it's your life. The magic wand is you. So that was a presentation I gave some years ago. And the real takeaway from that is that as a patient, someone that's gone through this process, that it really is, it's my decision at the end of the day. And so the work that we do here is really to enable the patient at that very, very fundamental level. So now I want to move forward through some other aspects of the experience for patient engagement. We're going to talk now a little bit about balancing policy and technology. I have a great CIO friend in the area here who said the best innovation is really technological. It's political. And I absolutely have come to realize that, and it's very hard for me to say as an engineer that that's true. However, as much as policy can sort of serve as a governor for technology, technology has a tendency to continue to move forward, and so we need to be sort of selective about how we move forward, and that policy tends to really drive the decision makings and the implementations of technology for the sake of patient engagement. So here's a fun eye chart I thought I'd show you. The two takeaways is you'll never figure this thing out, but I will say physicians are in the lower left corner, I found them, and patients happen to be about as far away as you can get in the lower right corner there. I have not seen payers anywhere in this mix, and it's, for those of you that are involved with CMS and HHS, this is really sort of part of your experience too, I would imagine. And so it really is a daunting experience. I'm going to focus today a little bit on the population health experience in chronic kidney disease, which kind of makes sense because that's sort of where I'm from. Very quickly, about 1 in 7 of the adult population will be affected by CKD. And I always have fun in meetings, which meeting rooms are usually about 8 or 10 people. And I'll say, okay, well, you're lucky because I'm sitting in this room with you. But if the moment that I step out of this room, you should start to fear. So if we've got about 70 people in the room, I'm one. So statistically, there may be others. And to be very serious here, and I always say this to folks, please be sure that you do take care of yourself. Check your blood protein and urine protein. It's very easy to do. Watch your blood pressure, and really that's probably the best way to take care of yourself as far as it gets to CKD. So part of the reason why I chose the population health example here is that the disease management really extends across a very broad set of conditions. And, so many people have CKD, and it's expressed initially through obesity and then diabetes, and then we end up receiving them through Northwest Kidney Centers for the sake of dialysis and eventual pancreatic and kidney transplant. So our use case is going to be Northwest Kidney Centers. As I had mentioned in the speech, dialysis was invented here in Seattle in 1960. 2 years later, Northwest Kidney Centers was invented to sort of commercialize the out-of-hospital experience. And modern-day dialysis is predicated on the model that was invented here through Northwest Kidney Centers. We're the third largest not-for-profit in the U.S., and we're consistently top-rated. And so you can sort of see my bias here because I am, as I mentioned before, I am a volunteer for Northwest Kidney Centers. So this is a great story about policy because dialysis is heavily, heavily regulated. How many people deal with CMS regularly, often? Okay, so you may sense the sort of the burden here. We work with for dialysis. We work with a bundled payment system, so sort of a fee for service. We do have clinical reports that we generate on a monthly and then an annual basis. And this is not, we don't. This is serious stuff. I mean, we have our patients dialyzing at least 3 times a week in center, and more in a home environment. Our treatment modalities tend to be spread between hemodialysis, which is what I went through, and peritoneal dialysis. And that last bullet point there is kind of critical. 25% first-year mortality rate. I mean, that's phenomenal. To think that a quarter of your patients aren't there a year later. And then if you look at a 5-year survival rate of 35%, that's heavy. So I put that bullet point in part because the policy really does dictate how we manage our patients, and we'll start to segue into the patient engagement side of things. But this is a tough nut to crack here. So we do have patient engagement. It's managed through something called conditions for coverage, and I suspect others in the CMS space may understand that. We do an annual survey, and we have something called CAPS for in-center, ICH CAPS, which is a patient survey, and the argument you could make the argument that it is patient engagement. As well, we also, as a patient, we have what are called IDTs, or interdisciplinary team meetings. But I say patients welcome, and it's a bit sarcastic, and I say it in part because I've gone through this process. The patient is ancillary. I don't believe that I ever felt like I was a part of that machine. It was a checkbox. It was really intended for the sake of a roll-up, and so we could do a much better job here. And I understand fully the fact that this is pretty heavy-duty stuff. But again, my argument is that it's at the end of the day, it's all about the patient. And if my life is literally on the line, I need to be more involved. So the good news here is that in the kidney care space, we are starting to engage the patient. I talked with one of our CMOs about a month or so ago, and she let me know, she just came back from Portugal. She let me know that there is work being done to better engage the patient. Her sense was it's been maybe over the past 10 years. I want to take a survey. Is that about what people are feeling, that maybe the past 10 years is where we start to think about patients being part of the equation? I would argue less than that, but I'm happy to take that. So Kidney Research Institute is an organization that Northwest Kidney Center has put together in association with the Department of Medicine here. It's a great organization. Jonathan Himmelfarb is the director. He's done phenomenally well. We have over $120 million in federal grants, over 1,000 papers published, and amazingly, 50 clinical studies active at any given moment. Many of those are patient-related. They have a little mantra, which is bedside to bench to bedside, which is phenomenal because patients are absolutely involved. And interestingly, they just convened in 2016 the Patient Advisory Committee, of which I know quite a number of people on that committee. So we are shifting, and I'm happy for this because, again, in this context with CMS and kidney care, this has been difficult to sort of get ourselves established. As well as something called KDIGO, Kidney Disease Improving Global Outcomes, just last month in February instituted their patient network. So there is traction here. It's just taking an awful lot of time. So the good news within this context as well is home dialysis happens to be an option for those patients that are interested in participating. I went that route. That's actually me there. I'm demoing home dialysis in-center to try to convince other in-center patients to participate as members of home dialysis modality. What's really great about this, and this really is patient engagement, we get to own our own clinical outcomes. And it's going to sound odd, especially for a provider, that I can say that as a patient, I get to manage my own care, which really equates to, in the home dialysis, I'm obligated to dialyze N number of times, usually 5 times a week. And I did nocturnal, so I would plug in and then go to sleep and then unplug the next morning. Generally worked pretty well. It's a noisy machine, and we did have some problems. But if I didn't feel like dialyzing, I could skip a day, and it was my choice. And that was the phenomenal part, because I felt like I had control. And that, to me, is kind of the key when we talk about patient engagement. That's my definition of patient engagement. As well, we get to generate our own PROs, and so we're obligated to do so. And this aspect of dialysis, now again, dialysis, this is heavy-duty stuff, and it's very regulated, particularly in center. Here's an opportunity where the patient has certainly a lot more influence on how they want to manage themselves. And so what's really interesting about this is it really underscores the value of the trust that gets established between the patient and the care team. I would argue that this is almost the care team expecting some level of compliance, and that's where that trust comes from. Because if we're not compliant as patients, that gets to be a very, very difficult situation. We have an online patient portal, and so this is part of the sort of the technical aspect. It works quite well. I get to log in. I can generate emails back and forth with my care providers. I can get my prescriptions refills and so forth, and we do generate PROs as a result of it. It's more or less it's obligatory, but it is a good way to stay in touch. And again, I feel like I'm in control. It really made me feel good. And of course, probably no surprise, I think Joy mentioned this earlier, patient engagement will yield better outcomes, and that's absolutely the case with home dialysis. As well, we have monthly on-site clinic visits, and we get labs drawn, and that's where we do our sort of compliance review and training, and that's where we sort of have the opportunity to work with the care team to sort of tweak how things have been going. Even better, and this is just something that started at the beginning of the year, is telehealth, and we're very excited about how we may be implementing this going forward. This really, to me, again, is a step forward in the right direction, because it's about patient engagement. It increases the immediacy and the intimacy between patient and provider, because what we're doing now is through telehealth, we have the opportunity to contact and work between the pair, patient and provider, 24/7. So if I have an issue any time of day or night, more or less, depends on the provider, I can contact and get some feedback. And again, this is in real time. This is not structured. This is by my clock, more or less. This, as I said, this just started at the beginning of the year through the Bipartisan Budget Act, which is really Chronic Care Act. And that really isn't just for the sake of dialysis. For those of you that are maybe familiar with this, it lifts a lot of the geographical limitations that we had prior to this Chronic Care Act as it relates to telehealth. Prior to this, telehealth was very, very difficult to implement. In fact, I believe there are new CPT codes that are available now through this act that make it a lot easier for the sake of billing, which didn't exist before. And so from a patient perspective, it's really sort of that last bullet point there, which is really exciting. For those of us that would be dialyzing at remote locations, instead of coming in to see my provider on a monthly basis, I could do it on a quarterly basis, and the rest of the time is done remotely through telehealth. That's, again, as a patient, that makes me feel very liberated. And again, I feel like I have certainly a lot more control about managing my own health. So why now? And this is going to get sort of kind of high level, but a little bit technical. So the upshot of it is technology, as I mentioned before, moves quickly. And so, boy, I mean, who hasn't used, for the sake of a telecon, used Skype or Zoom or anything else? These things are pretty ubiquitous at this point. And then finally, we're starting to realize the value of using telehealth in the healthcare space because it's low cost, reasonably secure, and we're starting to actually get some sort of traction in the space. And then finally, the gist of using telehealth in the CKD space for the sake of kidney care is to lower costs at the end of the day. And our expectation is fully that we'll be seeing some significant cost savings. And I'm going to also add, maybe politically, Alex Azar is the head of Secretary of HHS, and his father happens to have gone through both kidney dialysis and transplant, and I'm convinced that part of this legislation came through for very political reasons, and I'm thankful for that. But this is just how the world works, right? And then I think it sounded like there were some telehealth folks over in the corner over here. So there are really two ways that telehealth works, both synchronous, and most of us, when we're doing a Skype or a Zoom, it's live video back and forth in real time. Or you can do something called asynchronous, which is store and forward, which is I could leave a voice or video message with someone, and then they can sort of receive it on an as-needed basis. And then telehealth also is going to include remote patient monitoring, or RPM, which tends to be 24/7, and that there are lots of permutations of that. As well, it incorporates mHealth, which tends to be more, smartphone specific. And just sort of parenthetically, how ironic we call these smartphones when we rarely use them for phones anymore. I usually tend to refer to them as digital wallets. One side note, and this is still a drawback with telehealth, is that it is still absolutely required that we observe HIPAA requirements, which is very difficult. And there's talk of maybe relaxing or reviewing some of the HIPAA requirements that are out there now. Now, all said, engaging patients in the U.S. is terribly difficult, and this is just, it kills me because all this great stuff that we have available to patients, they just very, very hard to get them to take advantage of it. So we know that home dialysis provides better outcomes, 49% better, cost savings between 50 and 80%, so the incentives are there. But we only get about 10%, and I think in NKC it's about 15% of our patients are using home dialysis as a modality. So something's not right. And one of the amazing quotes, I think this is Alex's quote, the complete opposite situation exists where Hong Kong, 80% of the population are using in-home dialysis compared to our 9%, and even Guatemala is doing a much better job than we are. So something's not right there. So I want to segue now to sort of looking ahead, and this is sort of setting the stage that we've got a problem. We don't know quite what it is in the patient engagement space. My argument will be, and I think Joy touched on this, I think it's cultural in part. I don't think it's purely technological. And so I want to talk through that, and then I'll get into a little bit about the technology that I see valuable moving forward. And this is really a summary of what I saw when I attended the HIMSS conference earlier this year. So I'm convinced that in order to change a patient, we need to change the culture. So that's just my own personal perspective. I don't understand it, but Americans, we tend to be reactive when it comes to healthcare management. I'll give you a great example. I had a colleague come to me, and she said, my husband was just diagnosed with a serious heart condition. What insurance would you recommend? And I went, well, that's not right. But that's, she felt completely natural in asking this question, and that's how we think. We don't think about taking care of our health from a proactive or a prophylactic point of view. We tend to be very reactive. I think that's a cultural thing that needs to happen. I had a healthcare colleague come to me and say, optimized healthcare is a daily check-in and not an annual one, and that's absolutely the case. We just don't think that way quite yet. It's great to know that with the advent of the internet, patients are being able to maybe pre-diagnose themselves. WebMD was mentioned earlier. I've asked providers, colleagues that have, I've asked them, I said, is this a threat? What's the net? And they've all said, with one exception out of dozens, they said, we engage this. We appreciate this. We encourage this is good. And the takeaway as an engaged patient is a more compliant patient, and I think that's true. For providers, for those of you that are in the room, is that a thumbs up or thumbs down? I'm just curious to know. Yes, that's a good thing? Or is that a threat in any way, a challenge? Yeah, okay, good. Well, the one sort of pushback was they felt challenged. They said, I don't want to hear what a patient thinks they have. So I'll leave it at that. So I would rather be better. See, when I work with customers, I'd rather work with a very engaged, intelligent customer, and I'll not say more. So My argument is that I think younger patients are certainly going to be the driver for making healthcare more consumer-like, and I think there's an awful lot of power behind that going forward. I think younger people particularly see their providers as really advisors in their healthcare, and they're looking really across the spectrum. That they're looking for transparency. They want immediacy. We were talking earlier before this kicked off about EOBs. What is an EOB? Why do we have them? And a young person is gonna, if I look at it, I go, this is ridiculous. A young person's gonna say so doubly. So for me, I'm excited. I really think we're gonna see healthcare move forward at a much faster pace. And it's not because of me being older. It's because the younger folks have that higher expectation. So a couple of things that I takeaways from AI from the HIMSS conference. AI, we got an awful lot of traction in that space as it relates to cognitive computing, where you can parse huge piles of data and infer from that. And I didn't know this, but 80% of EHR data is unstructured, and that seems awfully high to me, knowing the back end of EHR systems. And so there's an awful lot of data to be had there that we can dig into. Judith Faulkner, who's the CEO for Epic, was at HIMSS, and she made an announcement. She called it a groundbreaking big data announcement, basically saying that all of the data that they've collected through their Epic systems, they'll be able to use using AI predictive analytics to infer for the sake of patient health, which is great, and that's the purpose of using big data and AI on top of that. I'll say as a patient, however, the implication is that she owns that data. And it's like, wait a second, that's my data. And so we'll have to sort of see how this falls out. I was surprised at how willing she was to be as open about that going forward. But anyway, NLP also an aspect of AI, natural language processing, a big deal, and I'm a big believer in this. There's a really great Cedars-Sinai project called Smart Hospital Rooms, and it's really putting an Amazon Alexa in the hospital room. And if you can just imagine that, you can sort of see where the direction goes for something like this. We're considering, well, I'm thinking about doing this for our home dialysis patients as well, because when you're dialyzing, you tend to have your hands full, and you still need to generate data. As well, there's a company called Nuance. They have something called the Ambient Clinical Intelligence, which will listen to a clinic visit and record that, knowing the voice of a provider and knowing the voice of a patient and being able to sort of arbitrarily pull that into a record, which is really fascinating. Now, the question is trust. I don't know if everybody quite trusts how NLP works, but it's gotten better over time, absolutely. IoT, Internet of Things, the data that gets generated here is going to be number one. And so by 2025, the talk is that that's where the bulk of the data is going to come from. And so there's sort of a handful of different applications. And to call out the last thing, this came up yesterday as I was putting the finishing touch on this. Stanford just announced their Apple Heart study with a 71% positive predictive value for their AFib events. That's amazing. And so IoTs, I think, are really the way forward and when I talk about IoT, it's sensors, right? Big area of interest here. And then the last place, which is my personal interest, and I'm happy to talk about this after the fact, is in blockchain technologies. This was a tremendous talk at HIMSS conference. I don't want to go down too much in the details of it, but most people know blockchain because of something called Bitcoin. When I say blockchain, they go, Bitcoin, oh, that's about making money, cryptocurrency. No, yes and no. So that's the pariah side of the equation. The panacea is it's been perceived that blockchain technologies will do everything under the world. No, that's not the case. So there's something called Gartner, the hype cycle, and you can sort of see the yellow dot. We're at that point where it's still hyped, but we're starting to roll down the hill. And I can tell you in the past year, and I've been involved in this area of technology for several years, this is the first year where it feels like there's a lot more value happening in this space. And I'm convinced as well, blockchain technologies, particularly as it relates to patient side of the equation, through something called self-sovereign identity, is really going to be valuable going forward, because it allows me as a patient to have access to my EHR records in a secure and longitudinal way, which means that interoperability can be solved in part through the use of blockchain technologies. So just to sort of summarize, where do we move forward? So we've got the framework that Danielle and her team had put together called MERA, MIRA. And it's all about really collaborating on the work that we do for the sake of the patient. You've sort of heard me now talk a little bit about where the patient sits in this. To me, it's all patient-centric. And at the end of the day, the work that we do today, particularly, is got to relate back to the patient, making it easy from the patient perspective, and generating the data that a patient will want to generate, will need to generate, or may have to generate, is kind of the key aspect of what we do moving forward. And that, to me, is exciting, and the potential is tremendous. So.